Respected teachers and my dear friends, so this session is a multimodality imaging and is going to cover the thick ventricle, the viability and then the Minoka. So the first lecture is about assessing the thick ventricle and I will call upon Dr. Darshan Jhala to deliver the lecture.
Good evening. Thank you for inviting me for this good talk. And what I'm going to talk today about is how to assess a thick ventricle. Now, what is a thick ventricle and why is it so important and why do we want to look at it? First of all, thick ventricle is anything which is an increase in the left ventricular thickness, which is actually a surrogate marker for the mass of the left ventricle. We started off with M mode, that is where we could assess only the thickness, and that is why this term got stuck. Actually, what we are looking at is trying to estimate the left ventricular mass, which has implications. So this could be either due to an increase in the wall thickness or due to the increased cavity size or both. And most common causes are either pressure overload or chamber dilatation, which occurs in volume overload. Of course, there are a couple of other things we started noticing later on. That was infiltrative diseases, which this of course is an older definition from the time of M mode. So this is essentially the etiology. We have pressure overload on one side, which is essentially obstructive lesions. Essential hypertension, of course, being something like a peripheral obstruction, and other types of coarctation, aortic valvular stenosis. Volume overloads will be regurgitated lesions, and the other things would be ischemic heart disease. Now one wonders why ischemic heart disease. Well, ischemic heart disease, basically when there is an infarct somewhere, the other areas of the myocardium start to compensate by becoming hypertrophic. So that's one of the causes of this. Athlete's heart has always been an issue with us. Dilated cardiomyopathy, because of its increased volume, it can have an increased mass, and infiltrating cardiac processes. So about 15 to 20% of general population, if you use some lax criteria, you can detect that. It's more often prevalent in the obese and in patients with hypertension. And these are supposed to be compensatory mechanisms. Now, why is it a compensatory mechanism? Because of the Laplace's law, which says that if you have pressure within the ventricular walls, that is the wall stress. Wall stress is inversely proportional to 2 times the thickness. So nature thinks I increase the thickness, the wall stress comes down. Wall stress reduces, the oxygen consumption comes down. This is nature's way of compensating. However, the advantages which we have gained from increasing the thickness is actually counteracted by worsening the diastolic function. Another thing that happens is fibrosis sets in, which eventually leads to a very bad stiff ventricle. So in short, left ventricular hypertrophy, which began as a kind of a compensatory mechanism, later on becomes a bad thing. And once it develops, it produces lots of heart failure, dysrhythmias, and sudden cardiac death. So it's not a good thing, so we have to detect it early. So this is the clinical impact of increased LV mass. In Framingham study, there was a significant increase, when there was a significant increase in the left ventricular mass, just 50 grams. There was a significant impact on the survival. And traditionally, those where the lowest LV mass have the best survival. So LV mass has been found to be a suitable measure for CVD risk stratification and a marker for subclinical disease. And this is how we calculate left ventricular mass. Actually, the one that we look here, this is the common method that we use. We take cross-section of the left ventricle. We judge the outside area, the epicardial, endocardial. You subtract this endocardial area from the epicardial area. What you get is the remaining myocardial rind. You multiply it using the specific gravity of the muscle, and you have formulas which gives you the left ventricular mass. This is one of the most practical methods, though not very accurate, but this is probably the best method we can have for assessing the left ventricular mass. For the clinician, easiest way to look at is when there is a left M mode, 1.3 centimeters to 1.5 is mild, severe is more than 1.7, and it's little different in women. When you have an unexplained maximum wall thickness of more than 15 millimeters in any myocardial segment, or septal posterior wall thickness more than 1.3 in normotensive patients, hypertensive patients you have a ratio of more than 1.5, this is considered to be increased wall thickness or LV mass. Now, having said that, there is a classification that has been made. This looks a little complex. Basically, what they have tried to do is tried to separate out various types of hypertrophy. They have called something called concentric knee modeling, then concentric hypertrophy, depending on the volume and the mass index and what is called the relative wall thickness. Now, this looks a little complex. It was important in the earlier days, but basically, why are we doing this? Because we are trying to find out the disease. B, we are trying to find out the prognosis in a given disease by estimating all this. So, basically the reason why we look for LVH is to identify some underlying disease and to prognosticate that disease. So, the another way of prognosticating the disease is to look at the Doppler tracings. So, when you have LVH with not much of a problem, you have more muscle and you have this E less than A. But when the pattern changes from this to this, in a LVH patient, you know that more fibrosis has set in and this patient is likely to be having more problems. So this is so far using the conventional criteria of trying to identify some problem by looking at the various types of hypertrophy and looking at the Doppler pattern trying to estimate the tissue. Well, so far what you have learned is there is an increased CV risk, there is you can distinguish between pressure and volume overload, and you can judge somewhat amount of muscle versus fibrosis. What's new now? What is new in 2024? So this is where the technology of speckle tracking comes in. Now speckle tracking is a special tissue Doppler technology which identifies speckles within the myocardium and studies its motion. And when this technology is applied to LVH patients, let's see how it helps us. This helps us in predicting the underlying disease. So let's look at a few examples. Now this is what is called a polar plot. Normally this all looks red. So when you take a patient of LVH and if you have this kind of a polar plot, well, only the basal septum. Now the center is the apex, the middle ring is the middle segment and the outer ring is the basal segments. So if you have only basal segments involved, this is most commonly in hypertensive patients. So, and when you look at the additional measure of GLS, it gives you another information. So basically a normal GLS with basal septal involvement, most of the hypertrophy is because of hypertension. So that's one way of identifying the disease. Second case you can take it as where the GLS is reduced. And if you look at certain specific areas of involvement, so when the numbers which are low, the ones which are in light pink, these indicate the reduced GLS in those particular areas. So if this GLS is reduced in hypertrophied areas with a normal GLS overall, this is specific pattern for hypertrophic myopathy. So you can distinguish hypertension from hypertrophic myopathy just by looking at the speckle tracking pictures. Another picture. Now this is a typical picture where what we call a cherry on top. So if you look at the bullseye pattern, this is again a case of hypertrophy. So other criteria would not tell you what this is. But if you look at the speckle tracking plot, you see that the apex is normal and the rest of it is abnormal. This is a typical pattern for a transthyretin amyloidosis. So you get this pattern, whether you get this pattern even in aortic stenosis sometimes, in which case the prognosis of that aortic stenosis patient is poor because he also has amyloidosis. So this is very helpful in a case of, even case of LVH. This is another case which I don't think I have ever seen. This is an Anderson-Fabry disease, which is an infiltrative disease, which has specific involvement in the posterobasal region. So the GLS is reduced and you have specific reduction in the posterobasal region. This is specific for Anderson-Fabry disease. Another thing that we have now added is what is called mechanical dispersion. Means the difference in time, how each segment reaches its peak contraction pattern. So most of them should reach fast at the same time. But if there is mechanical dispersion, for example, here, this is a mechanical dispersion plot, they all should be green. But there is red and green. That means some segments are contracting early, some are contracting late. So these are the people who, when such people are encountered in any condition, you have higher risk of ventricular arrhythmias. So in a given case of LVH, if you do mechanical dispersion, this is automatically given when you are doing speckle tracking on good machines. The incidence of ventricular arrhythmias and sudden cardiac death is much higher. So this is another modality which comes in. So in a given case of LVH, if you add these speckle tracking capabilities with mechanical dispersion, this is the kind of tissue diagnosis that you can make. Especially useful when you are trying to differentiate athlete's heart from other causes of hypertrophy. Now, athlete's heart essentially is a normal heart. So it has normal global longitudinal strain. It has no mechanical dispersion. So these are the type of people whom you can easily say that this is a safe patient of LVH. By others, from other patterns, you can identify the various disease patterns. So this is the recent advance that we have in the current, in LVH, in assessing a thick ventricle. So in conclusion, thick ventricle is an independent marker of increased CV risk. The type of hypertrophy helps us in differentiating between different pressure and volume overloads. Speckle tracking is a very useful method in identifying the underlying disease. Thank you very much.